5, 4, 3, 2, 1. We are live now.
Welcome
everyone to the next update in this webinar collaborative series between the Pediatric Orthopedic Society of India and the Pediatric Orthopedic Society of North America. My name is Mike Heffernan from the United States in California, and my co-director is Sandeep Patwardhan. The topic for today is an update on supracondylar humerus fractures, and we're very excited to have a fantastic faculty with us today. In our practices, there are fractures which are minimally displaced that we have to address, and there's some equipoise in terms of decision-making around those. There are also fractures that prove difficult to reduce. And then with displaced fractures, there can also be soft tissue injury, including pulseless supracondylars that come into our practice. So for today's agenda, we'll start with Dr. Jaime Denning from Cincinnati Children's Hospital, and she'll address type 2 fractures and her approach and thoughts on those. We'll then move to Jayanth Sampath from Rainbow Children's Hospital in Bangalore, India, and he'll focus on tips and tricks for reduction and pinning of displaced type 3 supracondylars. David Skaggs will then present on the pulseless supracondylar, and he's coming to us from Cedars-Sinai Hospital in Los Angeles, California, in the United States. After those three talks, we'll have a brief question and answer session, and then we'll wrap up with cases presented by Kapil Gangwal from Jaipur, India at SDMH Hospital. If there are any questions throughout, specifically in the question and answer session and then in the case discussion, please use WhatsApp and send those to this number, 91-971-292-5600. And the president of the Pediatric Orthopedic Society of India also will make a few comments at this time, and then we'll move into our talks.
Yeah, thank you, Mike. Welcome to the second joint webinar of Pediatric Orthopedic Society of North America and Pediatric Orthopedic Society of India. We decided to go for the second webinar. The reason is because of the great success we had with the first webinar. We did first webinar, and today I checked the number, and more than 2,000 people has watched this the first webinar, which we did few months back. And the success of the first webinar prompted us to go for the second. And I'm sure that the success of this webinar will also help us to convince our partner to go for the third webinar also. So with that, I hand over to Jaime Denning for her first lecture. Over to you, Jaime. Thank you.
Thank you. I just want to go back to my first slide. My topic is the type 2 supracondylar humerus fracture. What do I do? And I will tell you at the end of my 10 minutes what I do, but hopefully I'll give a framework over the course of the talk on how to think about a type 2 supracondylar fracture. Like Dr. Heffernan mentioned, there seems to be some agreement for treatment of type 1 and type 3 fractures. But just to be clear on what we're talking about here with the type 2 fractures, where there's a little bit more discrepancy in how to treat them, a type 2 supracondylar fracture by the Gartland classification is an extension fracture with an intact posterior hinge. And to get a little bit more into detail, the Wilkins modification of that subdivided it into type 2A fractures, which are pure extension injuries with no rotational abnormality or translation, and type 2 fractures that have some coronal malalignment or translation. And here are my examples of those on X-ray. And so just a little background, when you're making a decision on how to treat a type 2 supracondylar fracture, you want to be able to measure and quantify to help make decisions. So I incorporated this helpful image from a Texas Scottish Rite publication on measuring supracondylar humerus fractures type 2. You can see in the AP plane, you can measure the Baumann angle. On the lateral plane, you can measure the anterior humeral line. As we all know, generally the anterior humeral line intersects the capitellum, and there are several variations of that by age. So a lot of children less than age 4 to 5, the anterior humeral line will sit in the in the anterior third of the capitellum. Most children older than age 4 or 5, the anterior humeral line will intersect in the middle third of the capitellum. There are other measurements you can do on the lateral x-ray, the humeral condylar angle, also known as the shaft condylar angle. And in this paper out of Scottish Rite, the hourglass angle was a novel measurement that they made, basically intersecting or bisecting each part of the hourglass figure and measuring that angle. As with measuring any angles, you want to make sure that you know what the normal is. So what your goal is with treatment is to get things as close to normal as possible. So a Baumann angle has a wide normal range from 64 to 82 degrees. The anterior humeral line, as I mentioned, can vary by age, but in general, in children age 4 or 5 or older, you want your anterior humeral line to intersect or the middle third of the capitellum. And then the shaft condylar angle normal value is 40 degrees. The hourglass angle normal value is 177 degrees. And I just have one more slide on anterior humeral line, just to see how far off into the woods you can get on this topic. The anterior humeral line, the pure measurement, obviously has some variation based on age. So in various studies, people have done different things, like an anterior humeral line index, where you're actually measuring it's measured as a 0 if the humeral line is anterior to the capitellum. It's classified as a 1 if it's transecting the anterior third of the capitellum, and it's classified as a 2 if it's transecting the middle third of the capitellum. There are studies that show that this degree of fracture extension using the anterior humeral line index significantly is related to the failure of closed reduction and cast treatment. So that's a lot of detail just on one radiographic measurement, but I just wanted to demonstrate how this type of fracture, the type 2, why there's such disagreement sometimes on how to treat them. So let's get into what the treatment options are. With the limited time we have remaining, we're probably going to just focus on the closed reduction and casting and the closed reduction and percutaneous pinning as the two most common options for how to treat a type 2 fracture. You can also use closed reduction and taping or strapping with a cuff and a collar. I just wanted to show those as possible options with pictures from a study to show that the two options that we're talking about may not be the only two options available to you, but just with limited time, we'll just discuss these. I also tried to include references so that you can refer to these and look up the studies on your own when you have more time to do that. And I have a longer list of papers that you can refer to at the end of the discussion as well. So very quickly, I tend to be a person when I'm thinking about fractures that's pretty, I like to lump things into categories. I don't necessarily go into great detail on measuring certain things and making my decisions in the clinic or in the emergency department based on radiographic fine measurements. So when you think about the two choices for a type 2, you can do closed reduction and casting. The advantages of that are that it's a shorter intervention time to do a closed reduction and a cast versus doing a closed reduction and pinning in the operating room. There's also less risk of not having a general anesthetic and less risk of having a pin tract infection when there are no pins to get infected. The disadvantages of closed reduction and casting are that it's a less stable construct for a theoretically less stable fracture. That might not be the best choice. And you must check the alignment more often because the pins aren't holding it stable. So there's potentially more time of trips to clinic and more radiation while you're x-raying this multiple times throughout the healing process. Going into a little bit more of the support for doing closed reduction and casting in the literature, I included several studies. The details aren't necessarily important for this talk, but just the overall success rate of closed reduction and casting for type 2 fractures is 70 to 77%. So that's a pretty high percentage when you're presenting this to parents, when you're trying to help them decide using a shared decision-making model, whether closed reduction and casting or closed reduction and pinning is the right choice for their child. Some of the pointers, the success rate in closed reduction and casting is higher when you have the availability of sedation to do a successful closed reduction. There does seem to be some greater residual deformity in the sagittal plane in this non-operative or casting group, but the majority of those, even the 14% that had some residual deformity on X-ray, had normal motion or within 10 degrees of normal motion. The other thing is when you decide to do closed reduction and casting, if you need to change your mind later on, you want to make sure that you can pin it later on if they lose reduction. So you can do that up to 3 weeks after injury. And also increasing fracture extension on the injury radiographs can help predict failure of non-operative management. Moving on to the other choice of closed reduction percutaneous pinning, the advantages and disadvantages are basically the inverse of the closed reduction and casting. And there is literature to support closed reduction percutaneous pinning. Most notably, the AAOS clinical practice guideline supports closed reduction percutaneous pinning of all type 2 and 3 fractures. Some of these other studies go into a little more detail that fractures with initial rotational deformity, coronal malalignment, and significant extension are the ones that are most likely to fail closed reduction and casting. So those should maybe be the ones that you consider doing closed reduction percutaneous pinning initially. And then there's a meta-analysis that shows that prevention of cubitus varus and improved Flynn elbow criteria are achieved when you do closed reduction percutaneous pinning. So these are all important studies to take into consideration when you're deciding what to do. And as my last slides here, this is a case where I decided to do closed reduction percutaneous pinning. You can see that the things that I considered were on the AP view. There's a little bit of buckling here on the lateral cortex. And so you can see there's some AP or coronal plane deformity and not just a purely extension injury. So I decided to do pinning. Additionally, this is the same patient intraoperatively. You can see that you can actually get the coronal plane fairly well reduced with some pronation. But when I did the hyperflexion, got a nice reduction. But when I brought it back to 90 degrees where I would plan to cast it if I weren't going to pin it, you can see that there was loss of reduction. So I decided to use pins for stability. Here's a patient with initially less extension, no deformity in the coronal plane. And this one was treated with closed reduction and casting at 90 degrees. And this is a 6-month follow-up with maintained reduction and healing. So as my last slide, everyone likes a protocol. So I know that there was a lot of detail in 10 minutes on decision-making, but essentially if there's some coronal plane malalignment, that's when I consider using pins instead of just a cast. This is from the Spencer study, and this is a nice outline of how to think about these type 2 supracondylar humerus fractures and whether to treat with closed reduction and casting or closed reduction and pinning. Thank you very much for your time. And the list of studies that you can look at will be available on the TV.
Thank you, Jaime. That's fantastic. And next we'll move on to Dr. Jayanth Sampath to discuss reduction and fixation of displaced type 3 supracondylar humerus fractures.
Thank you so much to the Pediatric Orthopaedic Society of North America and POSI for this opportunity to present my experience of reducing and fixing type 3 supracondylar fractures. So my topic specifically mentions tips and tricks, so I'll stick to that. So the reason we need to know about supracondylar fractures is that it is the commonest serious fracture that we encounter in pediatric orthopedics. So I'll talk briefly about how to obtain a reduction and some tips, how to achieve stable fixation. And in my experience, maybe a third to 40% of supracondylar fractures have to be managed slightly differently. And the whole idea of the game is to customize the treatment to the fracture personality that you're dealing with. So there is more than one type of type 3 supracondylar fractures, which we will hopefully cover in this talk. So one of the important things I get asked by adult orthopedic surgeons is whether almost all supracondylar fractures can be close reduced. And I think the answer is yes, if you have a few tricks up your sleeve, which every, I think, fellowship trained pediatric orthopod does, or we tend to gain the skills over time. So important is to position the child properly. Secure anesthesia with an endotracheal tube is very important, particularly in younger children. You don't want to drag the child off the table. An arm board is important, or some people also use an arm table insert that's much, tends to protrude less from the side. And you can also put this child in the banana position, so you have the upper limb further out so that you can get a nice lateral without getting into the edge of the bed. And it's also important before you start reducing the fracture to get your C-arm set up correctly so the screen is opposite you, so you're not craning your neck to get a proper view, and the C-arm should come along the side of the table from the foot end of the bed. These are just small little tips that experienced surgeons use. I think Dr. Skaggs was the one that kind of formalized the reduction sequence that you first apply traction in 30 degrees of flexion to restore length. And that is seen by restoration of the olecranon fossa. And then you correct translation, either medial or lateral. Moving on to rotation, you pronate and supinate. Many people just pronate the forearm, but I find that some supracondylar fractures are better reduced in supination or mid-prone. So I try all three positions, see which gets the best fit on the AP view, and then proceed accordingly. And then I switch my C-arm to a cross-table lateral, and then I reduce the extension on the lateral view so that I get a good reduction. So this is the sequence that needs to be followed. So in addition to the AP and the cross-table lateral, it's important to get the medial and lateral oblique views at 45 degrees. These are called the column views. And this basically tells you that you've got a 360-degree accurate reduction. So the question is, what if it will not reduce closed? And many supracondylar fractures will not reduce closed, particularly the displaced ones that you are reducing the following morning. There's a lot of swelling of the elbow, small child, 2-3 years old. There are at least 4 augmented close reduction techniques that I use in my practice. The first one is a joystick or derotation wire, and I'll just use some case examples. There's an 8-year-old girl who had treatment elsewhere and then came to me a week after open reduction and percutaneous spinning. This is the immediate post-op X-ray that the patient brought along, and this was the X-ray at a week. That's a clinical photo. You can see that the open wound is opening up because the fracture is unstable. The fixation is not stable enough. There is more than 50% of translation. There's loss of reduction, and the pins are backing out. And definitely there is some rotation at the fracture site. So what we can do in the situation to get a hold of the situation, get control, is to place a derotation wire in the proximal fragment, not too proximally because you don't want to risk the radial nerve. And this gives you good control over the proximal fragment so that we can then correct all the components of the deformity, translation, rotation, etc. In this case, I was able to get good stability with 3 lateral pins. And the column views also showed that there was good reduction. The second is a Kapanji technique that I use infrequently. The original authors that described this technique used it in the prone position. I am not used to pinning supracondylars in the prone position. I use it in the supine position, but I use a bolster. So that gives me the ability to come from posteriorly, from behind the humerus, just to get the reduction. And the particular fracture where I really find this to be useful are the high sagittal obliquity fractures, and we'll deal with this in a later part of the lecture. So in those, the distal fragment tends to slide up posteriorly because of the high sagittal obliquity. So in those, you can pass a pin from posteriorly in an intrafocal Kapanji technique, and you can just lever the fracture down and then pass your pins in regular fashion. Something like that. You can either keep the Kapanji wire in place, or if it's getting in the way of your regular wires, you can even remove the Kapanji wire after achieving the reduction. The third is a mini open reduction. This is a favorite of mine, particularly when you have fractures like that. It's not projecting very well. So you can see that there is rotation and there is also an anterior spike. So you just go, you pass the pin in the distal fragment and then just make a stab incision, go lateral to the biceps. And I just use a straight hemostat to push the proximal spike and then just advance the wire across. And always making sure that you haven't got the artery or any other neurovascular structure. Just a case from my POSI friend, Dr. Neeraj from Nagpur. This is much better documented. He had 3 attempts of close reduction. And instead of using a hemostat, he uses a metal suction tip. And he also uses that to drain the hematoma if it's a fresh fracture. And that helps to achieve the reduction. And then he just uses it as a joystick or just as a pushing device to push the proximal fragment into place and again pass the wire. And this child went on to have a good result. The last one is when you have this so-called brachialis sign, where there is ecchymosis in the antecubital fossa. It's not a good idea to go messing around blindly with these because sometimes the artery or the median nerve, anterior trochlear nerve, tend to be tethered on the proximal fragment. So before you start reduction, just check for this. Here you can see that tenting of the skin as you are flexing the elbow. And this is called the pucker sign. A pucker sign is a sign that there might be some tethering of the brachialis or soft tissues. So in these cases, we do something called milking the brachialis in a gentle manner from side to side. Just press the brachialis in a proximal to distal direction just to release it off the proximal fragment. And then before you start the reduction sequence, again, flex the elbow and make sure that you've lost the pucker sign. So augmented close reduction techniques helps us to avoid open reduction, which is unnecessary in vast majority of cases. If you do want to open, use an anterior approach through a transverse elbow crease incision. The posterior approach gives the worst cosmetic result. It's a favorite amongst adult orthopedic surgeons to approach the elbow. In children, it's an absolute no-no because it results in a lot of problems. So use the transverse anterior approach if at all you want to do it, or you can go for the lateral approach. So what about almost perfect reductions? You can accept minimal rotation and translation up to 1/3 of the humeral width, but stable fixation is a must. So this is a child who again had a type 3 badly displaced supracondylar fracture. You can see that I've accepted a little bit of rotation in the lateral view and a bit of translation about 1/3 of the humeral shaft, but child has gone on to heal very well and has absolutely no functional deficit at 9 months follow-up. But you can't do that in the older child. This is again a case that was fixed elsewhere and then came to me like that with a more than 50% translation. And what happens in these children is that you get a lot of callus that tends to block up the coronoid fossa, and it results in blockage of flexion. And because elbow doesn't grow very fast, it remodels very slowly, and it can cause a lot of problems in the post-op period. So lastly, going on to stable fixation, just as we classify displacement according to Wilkins, we classify fracture pattern according to a paper by Bach et al. This is in the JPO in 2008. And they classified supracondylar fractures into 6 types based on obliquity. So you have the standard supracondylar, the lateral oblique, the medial oblique, and the high supracondylar. And on the lateral view, you can have a low sagittal obliquity or a high sagittal obliquity. And the reduction and fixation techniques for these vary, and one needs to be aware of how exactly to reduce and fix these individual fractures. Thankfully, vast majority of them are typical transverse or lateral oblique fractures, though medial oblique fractures do happen, and we need to be aware of how to change our pin placement based on what the fracture pattern is. So typical transverse and lateral oblique fractures, we can do a simple lateral only pinning. That's our preferred technique. All other types, you should consider cross pinning because you may not get stable 4-column fixation. So these are the 2 common fractures, and they can be fixed with the lateral only technique. If you have a medial obliquity fracture, you need cross pinning or a high obliquity. This is a atypical fracture that I got. It's a high supracondylar fracture that I still use the 3 lateral pin technique because it is still a lateral oblique fracture. So you have to take all these factors into account before you can decide what particular pin configuration you want to use. So sometimes you have these low supracondylar fractures, which you can confuse with a lateral condyle fracture. And the best thing to do in these situations is to perform an arthrogram, 1 ml of dye, dilute Omnipaque 300 dye into the soft spot of the elbow. Nicely visualizes the trochlea that is otherwise unossified at this age, and one can get a good trajectory of the medial pin, because low supracondylar fractures would benefit from cross pinning. So just to summarize, we have to classify supracondylar fractures, type 3 fractures according to displacement and obliquity, customize the pin configuration to suit the fracture personality, and achieve stable fixation for a good result. Thank you very much.
Thank you, Dr. Sampath. And we'll move on to Dr. Skaggs with the Pulseless Supracondylar.
I would first like to thank Dr. Denning and Sampath for sharing your masterful techniques. Those talks were filled with wisdom. Let's see if I can keep up with you guys. Okay, so the topic we're going to talk about is the pulseless supracondylar fracture. Now, this should scare everybody. The pulseless supracondylar fracture can be a problem. There's no question. So somewhere between 2 and 4% of supracondylar humerus fractures don't have a pulse. Now, it's no surprise why. The proximal fragment can be pushing right against the brachial artery, or may have even torn the brachial artery. So what we want to do at first is assess, do we have a warm, pink hand that has good perfusion, or do we have a white, cool hand that has poor perfusion? This is key in the assessment. If the hand is warm and well perfused, it's still an urgent surgery. I would not sit on that overnight. In fact, I've seen cases where the hand came in warm and well perfused, but then developed a compartment syndrome overnight with a poor result. On the other hand, if we have a white and cool hand that's poorly perfused, that is a middle of the night emergency. Cancel other cases, get that to the operating room immediately. If you sit on that, you can predict you will have a compartment syndrome, and there's a good chance, even if you approach this emergently, there's still a decent chance that you might need a vascular repair. So a white, cool, poorly perfused hand is a whole different world than a hand with good perfusion. And one thing that you don't need is an arteriogram. If there is no pulse and the hand is white, we know where the problem is. It's right there. An arteriogram is not going to give us useful information. All it's going to do is slow up the treatment of that child. Now, there's been a great study, and I love that this was already shown, looking at the pucker sign. So what is the pucker sign? It means that this proximal fragment went through the brachialis, stuck into the thick dermis, and has probably caused all kinds of damage in between. If we see a pucker sign, we should be particularly careful about the pulse, because usually the pulse will be compromised. Step one, before you do anything else, before you put on a cast, before you call the OR, simply apply gentle traction, flex the arm just 20 to 30 degrees, and so often, right then and there, the pulse returns. You feel like a hero, you've saved the day, things aren't quite such of a rush. Okay, now let's shift to we're in the operating room. We came in with a patient who is pulseless, and there's 3 different options. After you reduce the fracture, the hand could be 1, good pulse, good perfusion, 2, no pulse, no perfusion, or I'm sorry, no pulse, poor perfusion, or 3, no pulse and well perfused. These are the only 3 options. Let's look at them one by one. And I have to be honest here, assessing perfusion in the operating room can be challenging. There's betadine or iodine on the wound. The hand could be cool because it's been exposed, after having alcohol and other things placed. So take your time in making this assessment. So if you come in pre-op pulseless and afterwards pulse is present, well perfused, fantastic, things are okay. The clinical and Dopplerable outcome will be normal for many years to come and short term as well. No problem with this group. Now, what if you have, after the reduction, there's no pulse and is poorly perfused? You don't have to think here a lot, just do it. Open, explore. There is no way you should be leaving the operating room with a white, poorly perfused hand. So how do you do the approach? So as orthopedic surgeons, we tend to be afraid of things like arteries. But with a little bit of practice, usually you could just make a small transverse incision right at the antecubital fossa. Don't go deep, because there's going to be a nerve and an artery possibly right under skin. So just go through skin, open it up, and you might see what you need. If there's any question in the world, don't hesitate. Extend the incision to a boat race incision. Go distal laterally, go proximally medially, and open things up. And what do you see? I'm going to encourage everyone in the audience right now, pick up your arm, feel your bicep tendon. And just distal and medial at your bicep tendon, you feel this sharp structure right there, the lacertus fibrosus. Stick a clamp under the lacertus fibrosus, cut through it, boom, it opens up right to where the artery and the nerve should be. Now, they're not always there. Sometimes the artery and nerve are in front of the proximal fragment. Sometimes they're behind, and sometimes one in front and one behind. And sometimes, like you see here, you just see the ends of the artery. In that case, put a little clamp on it and call up the vascular surgeon. Now, most of the time, however, simply freeing the artery from the soft tissue around it allows the blood flow to return. Maybe you could put some lidocaine on it and certainly consider a compartment syndrome release. Okay, now here's the big controversy. What if the hand is pulseless but well perfused? So nowadays, most papers say if you have a well perfused hand, you're going to be okay because there's a really rich collateral circulation around the elbow in children. However, I think you do want to admit the patient to the hospital, watch them for at least 48 hours. I've seen a couple of cases around 36 hours post-op go bad and need a compartment release. You want these kids in a hospital if you can. So here's a great paper done out of Texas, and they looked at the kids who came in pulseless supracondylar. 20 of them had a restored Doppler pulse in a pink hand. Almost all of them did well, but you keep them in-house because here 1 out of 20 required a return to the operating room. And here's a study of 125 pink pulseless hands. It was interesting, only 10% of them had a vascular surgery, and all of them at 72 hours had the same rate of palpable pulses. So this shows a couple things. One, having a vascular repair doesn't always end up in having a pulse. And two, not having a vascular repair, if the hand is pink and pulseless, is probably okay. So one question now is, what's the role of the Doppler, the ultrasound Doppler? And the truth is that most studies show there's little evidence that a Doppler or ultrasound Doppler have any effect. Dr. Denning, please don't tell Chuck Mellon I'm saying this because he loves to show slides of pretty colors and things moving back and forth, and it looks cool. And it always makes me feel good to see a Dopplerable pulse, but you're not going to change anything based on that. If the hand is pink and well perfused, I'm not going to open someone up because they don't have a Dopplerable pulse. Okay, and this is a classic study out of Boston. We should all remember, after supracondylar fracture is fixed, the pain should be minimal. It should be manageable on Tylenol. And you see this frequently on test questions. So after supracondylar fracture is fixed, if there's increasing analgesia, increasing agitation and anxiety, and this gives me anxiety because I don't know the difference between anxiety and agitation. But if things are going worse, if the nurse is calling and the patient needs more morphine, think compartment syndrome. That's not normal. So the take-home message, if you have a pulseless supracondylar fracture and the hand is warm and well perfused, life is good, everything's going to be wonderful, you don't need an arteriogram, but this still is a middle of the night case. Pulseless equals middle of the night. Now, on the other hand, if you have a cool poorly perfused hand, that's an emergency. Get right up to the operating room, cancel other cases. And if you do see the pucker sign, operate soon. If there's poor perfusion, it's an emergency, get in there. Thank you, everybody. And I will welcome questions, or the leadership here could tell us what we do next.
Yes, David, I have received a question. The first question is from one of the POSI member, and he said that many times we give axillary block for operating these children. Now, the problem of axillary block is that the effect lasts for few hours after the surgery is over. So how do you evaluate compartment syndrome or developing compartment syndrome in that case?
I think that this is a very important question. I do not agree with using an axillary block for supracondylar humerus fracture, just for the reason you stated. You will have no way of telling postoperatively if the patient is in too much pain or if they are developing signs and symptoms of a compartment syndrome. So I personally do not recommend an axillary block when taking care of children with supracondylar fractures. I am certainly welcome for people to disagree with that because I also have no experience in it.
Thank
I agree
you.
with that. I think if there's ever a concern of compartment syndrome in a limb, I would feel uncomfortable with the block. So that would go for tibial shaft fractures is the other thing that specifically comes to mind. Even forearm fractures, if they're treated operatively, I'd be hesitant to use a block for those, but curious to see what everybody else thinks.
No, the problem is in India is that an axillary block is actually safer from a general overall safety perspective of the child in peripheral setups compared to giving a general anesthesia where monitoring facilities may not be available. So one, I think, has this is a practical problem where we have, I work in a tertiary children's hospital in an urban center, and I have access to pediatric, I have 6 pediatric anesthetists at my disposal. But that is not the case in many parts of India where surgeons, and you can't even transport those children because they'll be 300, 400 kilometers away from the nearest urban center. So whoever is the local surgeon has to manage that fracture in the best possible way. So I think that's a very relevant question. So I think my response to that would be, if there is a real risk of, if it's a 2B supracondylar where the practical risk of a compartment syndrome is practically nil, I think it's okay to give an axillary block. But then if it's a type 3 supracondylar or a pink pulseless hand, etc., I think one should make every attempt to give general anesthesia. What would you say, Kapil?
Yeah, in my practice, I never use a block for these kind of fractures. The anesthesiologists always are, of course, interested in that, but I stay away from that for these patients. Same for forearm fractures, like Mike said.
I would also say that
Go ahead,
just
Jamie.
practically going to say that I also don't use blocks for my supracondylars, but if in the occasion where that's necessary to avoid a general anesthetic, I'm wondering if there are the injectable anesthetics that have different half-lives. And so maybe using one that has a half-life less than 6 to 8 hours, if possible, when the risk of compartment syndrome is the greatest. I think that's reasonable. And also, like Dr. Skaggs was saying, sometimes the risk of compartment syndrome is higher, actually 36 hours after the fracture and not immediately. So by the time that you need to be able to do do an exam, maybe already the block is worn off.
I think Dr. Sampath made an important point here, that we have to weigh the risks and benefits. And if we are in a situation in which general anesthesia is more risky, then I certainly think it's safe to do the low risk supracondylar fractures with an axillary block, like a type 2 or even a type 3 that doesn't have any warning signs, that has a pulse and that is warm and well perfused. I think that's an important point.
So if I can sneak in a couple of questions I had for the POSNA faculty. After reducing even a white hand, oftentimes the perfusion returns immediately after close reduction. I think the literature states around 50%, and my experience is very similar. The question is, most of us don't have access to plastic surgeons in-house or a vascular surgeon in-house. So how long do you wait? And I have sort of seen my own practice. I've been in practice for 20 years now, and I've added 1 minute for every year of. So whereas when I was starting, I used to immediately call the vascular surgeon. Now I'm 20 years, so I wait 20 minutes after reduction, and then I find that more often than not, the hand does start to become perfused. And so, I would like the POSNA faculty to comment on how long you wait before you pick up the phone. Or do you just have a vascular surgeon, kind of looking over your shoulder anyway? You don't
okay, I'm with you. I have found that if you call a vascular surgeon, surgery will be done. And most of the time you don't need surgery. So I think waiting is very, very appropriate. I think waiting 20 minutes certainly is appropriate. And as long as the hand is pink and well perfused, surgery is not needed. There's so many studies that prove that. It's interesting that when I've given grand rounds at different places, if there's a hand surgeon in the audience, they say, "You're wrong. We should open that and fix it." So I think that the two specialties have different ways of viewing this.
No, I meant a white hand, right? A non-perfused hand will still, after reduction, 50% of them will perfuse, and the color will return, and we tend to watch them for 48 hours. So that was my question. My question was, one step further.
Wait, so you're saying you will have a hand that is white and poorly perfused and you leave the operating room?
No. We will keep the child in the operating room and just wait, with the child under anesthesia. I will wait 15, 20 minutes after a good, after I get my reduction and fixation. I wait 15 to 20 minutes. And more often than not, I find that the pulse will return. The perfusion will return, even if the pulse doesn't return. So, and then I take, once perfusion returns, I keep them monitored for 48 hours as recommended.
And I assume you have the angle maybe at about like 30 degrees or so, right? Not very flexed,
No.
like 30
This
degrees.
This is pinned. So it's stably fixed. So
but I think it also matters what the status before the reduction was. So if the hand was well perfused before reduction and then after reduction became poorly perfused, I'd be concerned about that and entrapment of the neurovascular bundle in the reduction at the fracture site. But if it was poorly perfused before, remains poorly perfused after, but is showing signs of slow improvement, I think that in my hands, that would be something that I would watch and hope that would continue to get better, and just very carefully watch that process.
No, the question is like how long you will wait, how long you will watch.
I wait 15 or 20 minutes before calling. I think that's a very reasonable amount of time. I mess around and do a lot of things that I don't think are necessarily useful, like putting warm saline on it and moving the position, just things that I don't think make a difference, but that's what I do to fill the 15 to 20 minutes.
I just shout at everybody around.
That's a good point.
Just distract everybody and hopefully it will return. So one more point I had was there was this trend that you can sleep overnight on a type 3 supracondylar fracture that is well perfused, no problems with neurovascular. But having followed that approach, I find that some of them are more difficult to reduce in the morning if you've left them like 8-12 hours. Which are the type 3 supracondylar? Are there any type 3 supracondylar fractures with normal neurovascular status that you would still fix in the night? Do you have anything like that, or they all get put to the operating list the next day morning?
There's
I
some
hope I'm clear
subtle,
with the question.
I'll start and then anyone else can jump in. I think there's some subtlety to that because I've seen the same thing. There are fractures that we get to later the next day that I wish we had gotten to a little bit earlier. I think that there is, if there's no neurovascular compromise and it's a type 3 supracondylar, the literature is pretty clear that from an overall outcome standpoint, it's safe to wait till the next day. That being said, there's probably some subtlety to that in the fact that what time it comes in at night, it probably makes a difference if it got there at 5 and you don't get to it till the next day at 12 versus it comes in at midnight and you do it at 7 a.m. I think there's probably some difference there. Anybody else have their thoughts on that?
Yeah, I'd say there's definitely a lot of subtlety too. And we are not always, when we're daytime on call, we're not always the person who's on the night before. So sometimes it's not us making the decision. But I'd say the ones that give me a little, at least thought of going at night rather than waiting to the next day are ones that have a large like medial metaphyseal spike that looks like it could get herniated through some fascia or muscle or potentially poke a nerve. Or ones that have more than like 2 shaft widths of displacement on the lateral where they just look extremely displaced in extension. So those are the 2 that would make me at least think about going at night.
We take one question before we go for the case discussion. The question is from, again, one from POSI member. He says that when there is a white pulseless hand, what are the ways by which you evaluate the hand? The first is by pulse oximetry. The second is by capillary perfusion. And the third is by needle prick and looking for the bleeding. So which are the ways by which you observe the vasculation or vasculature?
There is a study at Boston that showed a SaO2 monitor is not useful. So I'd say in general, especially if you're taking a test, oxygen monitoring is never the right answer.
What about the other 2? What about the needle prick?
Never done it.
Mm-hmm.
I just assume you're not doing this to an awake child.
No, it's not an awake child. The child is already under anesthesia.
Okay.
Okay, Jayanth, I'm sure that you must have done that this test.
No, I have not. I don't prick the fingertip, but I do use saturation monitor. There was a paper out of Singapore. I mean, it's been criticized since, but if I get a good waveform, even if I don't have a pulse, if I get a good waveform and if the saturation is 99%, that's a well-perfused hand. But as Dr. Skaggs says, they all go together. You don't need a saturation monitor to tell you that the hand is well perfused. It looks pink and there's good capillary refill, but if in doubt, I do use saturation monitor. It's just an additional objective documentation that the hand was well perfused after the reduction and fixation. So, but I don't belong to the pulse school. I belong to the perfusion school. So I go with perfusion. I do not check the pulse at all. If the hand is perfused, well and good, because I know that pulse will return in them. But I do know that there is a risk of compartment syndrome. So I keep the patient in for about 48 hours and watch them closely.
Thank you. Kapil, can we have your question?
Okay.
Sorry, your cases.
Yeah, sure. Excuse me.
So Dr. Denning, is Dr. Melman still using the colorful Doppler all the time?
He loves the colorful everything, especially the Doppler. So yes.
In cowboy boots. Yes.
Yes.
Okay, so let's run through some cases quickly. So 1 year, 6-month-old boy, fresh injury. Should we splint it, reduce it, or fix it? So anybody wants to take that? Jamie, what would you do for this?
That's so this one is interesting. So this falls into my category from today. On the AP, there's actually not a lot of coronal displacement, maybe a little buckling on the ulnar side, but this is a pretty low fracture. It's even looking kind of like a lateral condyle on the lateral, but I think I'm fairly happy to attempt a closed reduction and casting of this. If it came to the ED, I would do it with some sedation. If it came to my clinic initially, we would just do it with some oral pain medication. And I would try to flex it after reduction with hyperflexion in about 90 to 100 degrees of flexion and get an immediate post reduction x-ray to see where it was.
Okay,
so initial non-op.
So any thoughts of just leaving it like that since the child's so young? He's likely to remodel, just splint it. Any chance of doing that at all?
I would probably at least mold the splinter, the cast.
Okay. So let's go ahead. So the family wasn't too keen for any reduction, so they just splinted, and I think they've been to some orthopedists who said that it'll remodel and do well. So that's what was done, and he comes back 10 days later with this X-ray. So now he's close to 10, 11 days out from injury. That's the X-ray. What would you do at this point?
Would you mind going back to the last slide, please? So if we look at the anterior humeral line, that is not touching the capitellum. I think if the anterior humeral line is not touching the capitellum, that's an indication for surgery. You know, maybe in this very young kid, one could talk themselves out of it, but if you're taking a test, certainly, the capitellum must touch the anterior humeral line or you need a reduction, in my opinion.
I have one question then. So this is a type 2A. So a type 2A where the anterior humeral line touches the capitellum is also a 2A, and one that does not touch the capitellum is also a 2A. So should we be introducing one more subset in 2As based on whether the anterior humeral line touches the capitellum or not? Because now you're saying that the 2A1 can be treated non-operatively and the 2A2 can be treated operatively. Am I thinking in the right direction now based on the latest evidence in the literature?
So I think I would argue that it was a 2A1 on those first, or sorry, 2A on the first set of X-rays, but this one would imply some rotational instability.
Yeah,
so I don't think it's a 2A anymore. If
you go back, then I hope you understand my question. That there is subset of 2A, two types of 2A fractures.
Kapil, can you go back to the?
Yeah, I understand. There is, well, at least here, there is some disagreement on the treatment. And I think in my mind, if you go back to the previous slide, I agree that maybe you can make the argument that you don't need the percutaneous pins, but at minimum, a closed reduction would be necessary. And I think the important part of that is that it's not just putting a cast on with the elbow at 90 degrees. There has to be a similar to what you would do in the operating room, a hyperflexion maneuver. And honestly, I think when I look at the AP, I can see some indication that Bauman's angle is off a bit and that there's some angulation on the AP. So I see some angulation on the AP. So I'd probably be more aggressive than less aggressive with this and would side with Dave and put pins in. But there is disagreement with that. I think if the anterior humeral line does not touch the capitellum, then a formal reduction at minimum would be necessary, as opposed to just putting a splint on with no actual reduction.
Okay.
You guys are remaining true to your own publication on the anterior humeral line. I appreciate that.
So well, let's come back to the case. So he's now about 10 days out. Would you attempt a closed reduction or do an open procedure for this, or just let it be and remodel and see where it goes? What would be your take on this?
I would probably take this to the operating room and attempt a closed reduction with pinning. I think 10 days out in a 1.5-year-old child, they're probably going to have some callus formation, so it's not going to move easily. I don't think that I would open it up entirely, but I might do something like a little Kapanji technique to try and maneuver this into place. The rotational malalignment really bothers me on that lateral view.
Right. So, well, this is what we did. We took him to the operating room, manipulated it, was a little osteoclasis, and then we just went ahead and pinned it, and it healed up well, and he got good range of motion. So he survived despite the displacement.
So
I make a comment.
Yeah, go ahead, Dave. Sorry.
So and there's this paper which talks about this, that you can safely reduce these fractures even when they come in late or for late displacement. So yeah, you were saying something, Mike. Yeah.
My quick question would be, so your osteoclasis, how did you do that? What was your technique?
So just pushed on the olecranon and flexed the elbow. That was it. Yeah, it just cracked and fell into place. So this is the second one, 7-year-old boy. He's come fresh from the injury, fell off tractor trolley. The hand was warm, brisk capillary refill. He had a median nerve palsy. Radial pulse was not palpable. We had a handheld Doppler. We couldn't get any signal for the pulse. And the pulse ox was kind of fluctuating between high 80s to low 90s. So what would you plan to do for this boy?
I'll say the immediate thing that should be done is not to leave the arm in this position. Hopefully the arm was flexed up, to 30 degrees or so before a Doppler was done and before a pulse oximeter was done.
Right. So this is just the clinical picture when he landed up in the emergency room. Right. So. Yeah.
And as long as so this is an open fracture. So we need
got a
to
little
start,
puncture wound. Yes.
We need to start antibiotics immediately because there is brisk capillary refill. The hand is well perfused. So this is not an absolute emergency, but I would say it should be, up in the OR as soon as you can practically, because when you have an open fracture like this and an absent pulse, there is a much higher risk of compartment syndrome. There's been much more soft tissue damage already done, and we want to fix this sooner than later.
Right. So the boy was taken to the operating room. These are some C-arm images, which shows the fracture. That's so we pulled on it, tried to reduce it, and so that was the kind of reduction that we got. We pinned it. Now, at this point, the hand continued to have a good circulation. So it was pink and good capillary refill, but there was no radial pulse. What would you say to this? Would you accept the reduction, or would you be concerned about something?
Well, may I ask a question? So there was a hole in the skin. It was an open fracture. In that case, I think I would probably open it up just a little bit more and wash it out, just in case some dirt got into the wound. And then I think you're more likely to be sure you're not capturing soft tissue at the fracture site. I'm a little bit concerned at the lateral view right there where one sees the gap. There could be soft tissue in there, even if it's not necessarily the artery. It could be tissue near the artery. It kind of pulls the artery at a funny angle and increases the risk of developing a problem later over the next day or two. So that fracture gap there concerns me a little bit.
So would that be your practice for all kind of supracondylar humerus fractures, which have a little puncture wound, that you'd be more likely to just make a little cut and open it, wash it out, rather than just
I personally would. If it's a 2-centimeter incision, it's not going to be cosmetically bad. I think there's very little risk in doing that. I think the risk of not washing out an open fracture is much greater.
Absolutely. So the little gap on the front side was a little bothering to us also. So we took some oblique views just to confirm that the fragments were apposed well, and those are the medial and lateral rotational kind of views. Would you recommend at this point that we open the fracture up and check it still, or would you be okay to accept it?
So is the hand well perfused at this point?
Hands perfused, so circulation's good. Yeah.
If the hand is clearly well perfused, I would accept this.
So
Others?
that's what we did. We accepted it, and that's the child in the post-op 1 day out. So he's moving his fingers. There's not too much swelling, but the nerve palsy is persisting. So would that be a point of concern in this child, since there's a nerve palsy and there's absent radial pulse? How would you observe this child? How long would you like to keep this child in house? So we kept him for 48 hours, but with children with nerve palsy, would you keep them longer, or would that be okay?
48 hours sounds good to me. And I think it's important to distinguish between, because I think I heard you say median nerve palsy, but on the slide it said AIN. And in my mind, there's a difference between the motor AIN palsy and a sensory. The child would not be able to sense if there was pain in that compartment. So I would follow that child a little more closely. And it may make me use a different type of immobilization. For example, a splint where we had access to the volar compartment post-operatively. Whereas an AIN palsy like this, it may take days, it could take hours, days, or weeks to come back. So that would not be a point that would make me keep a patient in the hospital. So I think from a vascular standpoint, 48 hours sounds good.
Okay, so that's what was done. And that's at 3 weeks. The fracture showed some callus and the K-wires were removed. The radial pulse came back at the 1 week follow-up visit. We could feel the palpable pulse, but he had the persistent nerve palsy. And those are follow-up images. He regained elbow range of motion and function in about 2 months, and the nerve function returned as well.
Very nice case.
So those are just some quick references. So both these papers actually say that in the presence of associated nerve palsy, there's a higher risk of compartment, and one should be tilting towards exploration rather than waiting out. But this child luckily did well. And this is Donald Bay's article in which they said extended monitoring versus surgical exploration for those who have anti-intraosseous or median nerve palsy. So let's go quickly to the case.
No, Kapil, the time is already over. So I request Mike to have a final comment, and then we will end the session.
Sounds like a plan. This has been a great discussion, fantastic presentations, and we thank all of our faculty for participating. The question and answer session and in these cases, I wish we could keep going because this is great conversation and I'm really enjoying this. But I thank you all, and we thank you all for this fantastic webinar, and for the listeners and watchers, we hope that this is helpful. And with that, I think we'll close this webinar and we'll look forward to the next.
Yes, thank you.
Thank
and
you.
bye-bye. Yeah,
Thank you.
You are.
Thank you.
Right.